Good afternoon, everyone. My name is Sarah, and I'll be your conference operator today. At this time, I'd like to welcome you all to the Hospital Management of PD Patients conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question-and-answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you'd like to withdraw your question, please press the pound key. Thank you. I'd now like to turn the call over to our host, Ms. Myla Renaud. You may begin your conference.
Thanks, Sarah. Hello, everyone, and thank you for joining us for the latest session of the DaVita PD webinar series. This series covers the key clinical elements of managing patients on PD and is recommended for all DaVita medical directors, nephrologists, and nurses who have or plan to place patients on peritoneal dialysis. Today is a mix of physicians and DaVita teammates, and we're happy to see that there's such growing interest around PD therapy. For the nurses in attendance today, you are eligible to receive 1 continuing education credit for today's presentation, as well as 1 credit for each of the previous webinars in the current series. And I'm going to give you guys the STAR Learning code right after our Q&A session before we hang up on the call, and I can also email it to you as well. Reminder, all of our webinar sessions are recorded and available for on-demand access. We'll sometimes reference previous webinars and the current webinar, so feel free to go back and watch the past ones as a reference. The presentation will include a Q&A session at the end. You can ask questions in multiple ways. You can wait until the end of the presentation and ask your question in person, or you can type it into the chat box of your webinar panel, and I'll go ahead and ask that question for you. This is Avoiding Hospitalizations and Managing Hospitalized Patients in PD. And I'm going to pass it on to our very own Dr. John Moran, who will introduce today's speaker. John?
Hello, and I'd like to add my welcome to everybody who's dialed in. I'm sure it's going to be a really important and really helpful presentation. I have the honor and the pleasure to introduce to you Dr. Mark Shapiro, who you probably all know already, but let's just go over Dr. Shapiro's career. Assistant Clinical Professor of Medicine at the University of California at San Diego, and he serves as the Medical Director of 2 DaVita clinics and as the National Medical Advisor for DaVita's peritoneal dialysis programs. He has a graduate degree in microbiology from UCLA and completed medical school at the University of Pittsburgh. His internal medicine residency, chief residency, and nephrology fellowship all took place at UC San Diego. Shapiro served as the Western Division Peritoneal Dialysis Medical Director for Gambro Healthcare from 2003 to 2005, and presently is the National PD Medical Advisor for DaVita. He's also a member of DaVita's Physician Council and Pharmacy and Therapeutics Committees. He is a partner in the Palomar Medical Group and maintains an active private practice in Escondido, California. Dr. Shapiro and his 3 nephrology partners oversee the care of approximately 80 PD patients in San Diego County and have consistently maintained greater than 30% of their ESRD patients on PD. They also manage one of the largest in-center nocturnal dialysis programs in the country. So if you need PD, you need to move to San Diego to have Dr. Shapiro as your physician. Please take it away, Dr. Shapiro.
Well, thank you very much, John, and hello to everybody. I do fully realize that all of you have other things to do, and I want to thank you for getting on the call. I also understand that there's almost nothing as painful as sitting and watching a computer screen for 40 minutes while you like me drones on and on. So I promise to try to make this as interesting and as informative as I can, and I plan to use lots of inflections in my voice to make it sound like it's more interesting than it even really is. Very little data published to support how to prevent and how to manage PD patients in the hospital. So I'm going to give you what I've been able to find in the literature, but I'm going to also rely very heavily on my own personal experience, recognizing that personal experience is dangerous because other people's personal experience sometimes is really different. I also realize that a large majority of the people on this call are probably outpatient nurses and outpatient teammates that you really don't get into the hospital very often. But I'm going to argue to you that the hospitalization of any dialysis patient is truly a sentinel event. It's an event that should be avoided at all cost, and getting the patients out of the hospital as quickly as we can is important, and coming up with strategies to prevent those hospitalizations is important, and then also to make sure that we're doing as good a job as we can. Even though you might be a nurse in an outpatient clinic, I think that the role that you have in terms of preventing patients from being hospitalized, they don't get re-hospitalized, and also really trying to make sure the care that they receive in the hospital is optimal, I think that's probably something that all of us can probably do a better job on. Now, start off with this USRDS slide that simply looks at both PD and hemodialysis hospitalizations over the last 15 or 20 years. I realize that you can't always compare PD and hemo, but what I think you can do is compare changes over time. And I think this slide pretty well demonstrates that on the PD side at least, we've reduced hospitalizations very dramatically over the last 15 or 20 years. I mean, it used to be well said that patients on PD were hospitalized more often than hemodialysis patients, but as you can see, that's no longer true. And although the length of stay and the bed days per year between the two modalities is the same, these curves, I think, really demonstrate what a better job we're doing nowadays in terms of taking care of our PD patients. And to drill down a little bit into PD hospitalizations and look at the reasons for admissions, you can see why there's such a reduction in the frequency of admissions. On the cardiovascular front, which is the most common cause for admissions of all dialysis patients, we've seen about a 20% reduction rate in the last 10 years. On the peritonitis side, the reduction rate is far more dramatic. And I'm willing to bet you money moving forward that we're going to see a much greater reduction in peritonitis rate admissions even moving forward. We certainly know that within DaVita, we've seen 30 or 40% reduction in peritonitis events over the past 3 years. So I think these curves are going to continue to move in the right direction. But even all being said, I want to point out one of the worst things about a PD patient, any dialysis patient being hospitalized, and that is that more than a third of those patients will be re-hospitalized within 30 days after that admission. And, this is really kind of a scary thing. This is one of the reasons why I would say to you that every admission of a dialysis patient is a sentinel event. And the question is, even if you work in an outpatient clinic and never even get close to a hospital, this ought to be an event that generates activity in the clinics. Every patient that's hospitalized, I argue to you that patient needs to be seen within 7 days, and all sorts of things should be done to try to make sure that your patient doesn't become one of those 36.3% of patients that will get readmitted in the next 30 days. Talk about that just a little bit more moving forward. And so, why do PD patients get admitted to the hospital? The common reason is related to cardiovascular disease, as is itemized here on the slide, myocardial infarction, strokes, and also lower extremity circulation problems, right? Peritonitis still remains high on the list along with other infections. Access issues fall under this list. I also want to later on talk a little bit about the fact that because PD patients perform self-care in the hospital, our ability to get them out of the hospital is sometimes compromised because these patients have to be functional enough to kind of pick up their own management at home. Maybe like a hemodialysis patient who can go to a nursing home or go home and be shipped back and forth to the treatment center without a participation. Our patients have to perform self-care in many cases, don't have a caregiver to provide it. And so I think this is one of the under-recognized reasons for patients to end up in the hospital and to stay in the hospital longer than they otherwise would. Okay. So let's talk a little bit about things that could get done in our outpatient clinics to try to prevent hospitalizations. And again, there's not much literature to support this, but I'm going to do the best that I can to talk through this with you. The first thing I'm not going to talk about is optimizing volume management or preventing peritonitis. Number 1 and number 4 are entirely separate subjects that we could spend hours discussing, so I got to leave those alone. Okay? I do want to focus a little bit, though, on item number 6, which is the close follow-up and after hospitalization. Let me just talk about that a little bit. Most of our clinics really don't have a process for addressing patients after they're hospitalized. If you agree with me, every hospitalization is a sentinel event, then sentinel events ought to generate some sort of formal activity. And I argue to you that you ought to have a formal process in place in your clinic that you recognize a patient has been hospitalized, that a series of steps take place. The first step, in my opinion, would be to make contact with the patient. You're a nurse in your clinic, and you find out that one of your patients is hospitalized. I would say the first thing that you need to do is touch base with that patient or with a family member. I think that's a really important process that many of us don't really do in an organized way. The second thing, or last thing, would be when the patient is hospitalized, what is it that you and your clinic do to provide support and for that patient? I would argue that patient needs to be seen in the clinic within just a couple of days, certainly within a week. What would you do with that visit? You would go over the medications and ensure that there weren't changes made in the hospital, because so frequently there are changes made in the hospital that the patient doesn't even know about, right? Or certainly that you don't know about. Many times the physicians taking care of patients in the hospital are different than the ones that take care of them in your outpatient environment. And so making sure the medications are correct would be important. Other things might include making sure that the patient gets physical therapy if they need to, that they get a home care nurse visit if they need to, make sure that they go to a wound care clinic if they need to do that. There might be physician office follow-up that's been recommended that the patient isn't going to do unless somebody helped the patient get there. Okay, things like volume adjustment. Maybe it's more relevant for our hemo patients, but nonetheless, there's a variety of things that I think you could do with a checklist after every admission to try to minimize the likelihood that the patient get rehospitalized. We could talk about that for a long time, but think about that. Think about what is the process that you would have in place in your clinic to address patients after they get hospitalized. If you have a process in place, this is the kind of thing you talk at your QIFA meeting. You sit down and say, let's talk about what we do and what we don't do, and let's try to formalize a process to do a better job. So I'll talk about some other things then.
Hey, Mark?
Yes.
I'm so sorry to interrupt you. Just one housekeeping note. I've got a couple of messages from individuals that said that the slides are not moving. If you guys are having that problem on your computers, maybe you want to log out and log back in. Those folks have done that, have had some success. Sorry, I have to go right ahead.
Okay, thank you. I don't have any idea what slide number I'm on because it doesn't show that to me. But right on the slide that says lower cardiovascular risk. We know that cardiovascular disease is the most common cause of death in PD patients, and it's probably also the most common cause of hospitalization. And I want to talk about modifications that we can make as outpatients to try to reduce the risk of hospitalization and cardiovascular death in our patients. When we talk about lifestyle modification, what we usually are talking about are things like smoking and exercise. And there's not great data on either of these studies, but there is a pretty good large study that identified that dialysis patients who smoke have 65% higher mortality rate than patients who don't smoke. And this data on what happens when patients quit smoking, I think that almost everybody would agree that having a dialysis patient who smokes quit smoking will over time reduce their cardiovascular mortality and probably also reduce hospitalizations. We, of course, know that patients shouldn't smoke, but I wonder how aggressive we are at really talking about those things with our patients in our clinic visits. Okay? The thing to mention with lifestyle is exercise, and there are a variety of studies that support the notion that regular exercise reduces the risk of things like falls and hip fractures, which of course lead to hospitalization. You may not know that simply being on dialysis and having a diagnosis of ESRD allows a patient to qualify for physical therapy. But I think we probably underutilize physical therapy in our patients and underutilize our conversations about exercise. Okay, on to aspirin. There has been a randomized controlled trial looking at the use of aspirin in dialysis patients. There's not really very good data supporting the fact that aspirin at a low dose or at a larger dose reduces hospitalizations or improves cardiovascular mortality. I will tell you the evidence that is out there supports the use of aspirin after myocardial infarction. In our clinic, though, we do have aspirin on our list of things that we recommend to patients. I'm going to talk about statins a little bit, but that's a lot of debate on that subject, and I'll talk about these other things a little bit also. Addressing the use of statins, cholesterol-lowering drugs. I may have heard conversations amongst physicians that leave you very confused about whether or not we should be treating our dialysis patients with statins. And the reason that there's confusion is because the studies that have been published have, in general, not been very supportive that the use of statins reduce the cardiovascular risk in dialysis dialysis patients. This is probably the most impressive study that's ever been published using a drug called Vytorin, which is statin plus this other cholesterol-lowering drug. Initially, what you see from the study was a 17% reduction in the risk of a cardiovascular event, but that study was done in a mixed combination of hemo and PD patients, but also CKD patients not on dialysis. When you look at the subgroup analysis of just patients on dialysis, as you can see in yellow on the right of the slide, there was only about a 1.5% absolute risk reduction. Now, that still means that the use of statin in those patients reduced the risk of cardiovascular events, but there's no reduction in the risk of death. The point to this is that we don't really know if statins are that good for these patients, and so there's a lot of debate. Even within my own practice, we have one physician who absolutely believes that statins are useless in dialysis patients. The answer to this that I want to point out to you is that when they look at these subgroup analysis of certain patient populations, what's kind of turned up is it may be that diabetic patients who have elevated LDL cholesterol levels may actually truly benefit from statins. So it's hard for me, however, to give you any dogmatic advice about what to do. I know in our practice we do include statins as a risk reduction modifier, and in my own personal practice I do put people on statins if their LDL cholesterols are elevated. For me, it means greater than 130. And it's really hard to be dogmatic about whether this is something that's really that helpful or not. With inhibitors and ARBs, there's really no data that I know of that addresses hospitalization. But there are data, this particular study from Toronto and Shanghai that looked at mortality in PD patients when they're on ACE inhibitors or ARBs. And as you can see, there is a reduction. There was observed a reduction in mortality when drugs were used. When you think about the other benefits of ACE inhibitors and ARBs, such as preservation of residual renal function, this has led to most people recommending the use of ACE inhibitors or ARBs in patients who require blood pressure control. Whether all patients should be on it or not, I think is not answered yet. Beta blockers, there's never been a study that has ever shown that patients on dialysis benefit from beta blockers. However, this was a study that looked at a specific population, in other words, patients who have a dilated cardiomyopathy. And as you can see, when you look at dead 48 months or hospitalization at 24 months, you can see that patients who were on a beta blocker show a reduction in these two indicators. But this, again, just a selected population of patients with dilated cardiomyopathy. There's other data supporting the use of beta blockers in patients after myocardial infarction. There is no data supporting beta blockers in the use of patients otherwise as a preventative health measure. Okay? What's funny to me, and I didn't know this until I prepared for this presentation, is the most robust data of all for preventing hospitalizations may exist for the use of vaccinations. There are two studies that both mined into the USRDS database, and they're both from about 7 or 8 years ago. The actual data comes from 7 or 8 years ago. Look at what happens to survival and, in some cases, hospitalization related to the use of vaccinations. And you can read this slide. What you see from both studies that are on this slide is patients who received both a pneumovax and so an influenza vaccine significantly improved survival and hospitalization rates compared to patients who didn't receive those vaccines. And got both. That was better than getting just one or the other. Now, say about these studies is that back in 2005, only about 26% of the patients were actually getting vaccinated. And people who got vaccinated tend to be older and sicker and more likely diabetic than the patients who didn't get vaccinated. The problem with studies like this is they're always prospective and observational. And it might be that people who refuse vaccinations are sicker or have bigger problems or less compliant. You never can draw complete conclusions. But I think that this is pretty impressive stuff and really supports our policy of trying to get all of our patients vaccinated. Okay, and so what I would say regarding all of this is it's not good enough to vaguely know that you want to do these things. You really want to have a process in place. And so in our clinics, we have a process, and our process is using a standardized checklist on our monthly progress notes. These are the notes that the physicians fill out every month when they see the patient. And we have a checklist that includes all these things. And the idea is the physician is supposed to review each case and identify whether these patients have these things on their medication list if it's appropriate. We don't include other things. We could arguably include things like echocardiograms, but we don't. But if you think that you or your physicians are just going to remember to do this stuff, that's not going to be the case. The only time you're going to be able to institutionalize this within your program is if you formalize the process. And if you go back and see what Doki says, here it is. As recommended, if there's a history of atheroembolic events and may be useful in primary prevention, then that if you're going to use anything for blood pressure, you use an ACE inhibitor, ARB. Recommend the use of a beta blocker, specifically carvedilol, because that's what the studies were done. After cardiac infarction or after if the person has systolic heart failure. We do recommend an echocardiogram at the initiation of dialysis and then every 3 years. And then that we examine patients for peripheral vascular disease, but don't recommend a lot of ancillary studies in that regard. But I'll tell you for sure that most of our programs do not have a formal process for doing these things for our patients. Okay. If you don't have a formal process in place, it means you're not going to really do it. All right. So moving on quickly, because I'm going to run out of time. End up going to the hospital. You don't want them to, but they do anyway. The first thing you've got to have is a really robust and aggressive way of making sure that if the patients go to the hospital, they follow through in a series of instructions in an appropriate way. These need to be instructions that are written out for the patient, or ideally tattooed onto their forearms so that they can always find those written instructions, right? So nobody should ever go to the ER without calling the PD nurse, in my opinion. Nobody should ever go to the ER without collecting a fluid sample from their belly and that stuff that's listed in item number 2. And because nobody should ever end up in the ER without either the nephrologist or the nurse being called directly by the ER before the ER starts doing anything to the patient. I don't care if this is the weekend. I don't care if it's the middle of the night. This is what, in my opinion, should happen. Okay, so let's talk about a simple case. A patient calls you at 8 o'clock at Saturday night. They've got cloudy PD fluid when they're hooking up to their cycler machine, a little bit of abdominal discomfort, not quite clear, no nausea. It's Saturday night, and you clinically suspect the patient might have peritonitis. What does the program do? Well, some places would say, come to clinic right now. Now, easy to do on a Tuesday morning, a lot harder to do on a Saturday night. Okay, you guys do that. That would be great if you do. But I'll be honest, most programs don't really come in at Saturday night to see their patients. You could have a patient to come in clinic first thing in the morning. First in the morning, in this case, would be a Sunday. You could also do what most people have historically done, which tell the patient to go to the ER, and that's what people historically usually did. And of course, we always have some people who choose item number D. If you look at the patients on PD present with peritonitis, it's really interesting that most patients present on weekdays, and today seems to be the day when the most patients present with peritonitis. Now, does that really mean that Monday is a more dangerous day than a Saturday? And the answer, of course, is no. I think the reason for this is, first of all, patients on Sundays don't even call you. They get a cloudy bag and they figure they're going to wait till Monday to call. So I think some people allow their peritonitis to fester over the weekends for longer than they should. I also think that you probably have contamination events that occur on Saturdays and Sundays, where once again, the patient doesn't bring it to a nurse's attention, and so the contamination event turns into peritonitis. And so then the patient comes in on a Monday or a Tuesday. What's kind of interesting from this data is that hospitalization rates are much higher if they present on a weekend. If you call on a Saturday night with a low-grade peritonitis and you send that patient to the ER, that patient's going to end up in the hospital. If that patient called you on a Tuesday morning, that patient would probably be seen in your office. And so you've got a really, really good way of trying to manage patients on the weekends and at nights so that they don't end up going to the ER and getting admitted to the hospital. Now, if the patient does present or call you with this, the process is simple, and everybody ought to know this already, right? And it is. I'm not going to read it. But nowadays we have the ability to initiate antibiotic therapy at home. The patients keep 2 750 milligrams ciprofloxacin tablets at home. And if you call about a contamination event, or if you call about early peritonitis where the patient isn't really sick, you follow this process, initiate antibiotics at home, and keep the patient out of the ER. That's what we should be doing, is keep the patient out of the ER. the patient ends up in the ER anyway, we support the patient, make sure the patient knows what to do, ensure that this process gets done properly. Now, I believe that IP, intraperitoneal antibiotics, are better for peritonitis than IV, but the truth is, in the ER, it's easier to give it IV, and it results in much smaller delays. A lot of times, if a person presents with peritonitis in the ER, I'll have the ER give them a dose of IV antibiotics and send home and have them come back to the clinic the next day. Unfortunately, most of these patients, though, will end up getting admitted to the hospital because it's sometimes easier for the nephrologist. Again, I think antibiotics should be given IP during hospitalizations, where the PD cell white counts. The count does not predict the outcome. It's irrelevant to the outcome. But we recommend, like ISPD does, that if the infection is really not beginning to clear after 5 days, we do recommend catheter removal, some caveats. The key, though, to administering IP antibiotics in the hospital is you need to make sure that they get a long enough antibiotic dwell. We typically switch them to CAPD. We usually leave them on the same PD prescription, but you have to make sure they get a 6-hour dwell. In the context of avoiding hospitalizations, I want to bring up the subject. We know that when we give patients antibiotics, it changes their intestinal flora. And we had 2 cases last year of very bad Clostridium difficile enteritis. And recently there was a large study that was published looking at the use of probiotics in not just patients, but in the general population when they receive broad-spectrum antibiotics. And they identified that there was a 66% lower risk of developing Clostridium difficile if you gave probiotics during the antibiotic treatment course. And I'm now considering whether I might want to start giving my PD patients probiotics during their antibiotic courses. Probiotics are very safe. I've never seen a complication or heard of one. A relatively benign thing. And these patients get Clostridium difficile. It could be nightmarish, right? We've lost patients to this before. Something to consider. The other thing to consider is you give your patients broad-spectrum antibiotics, whether the use of fungal prophylaxis is worth considering. I don't have time to go over this in great detail. There is some controversy about the use of fluconazole because of concerns about drug resistance. However, I will show you the only good study that I've ever seen looking through antifungal prophylaxis. And this study using diflucan fluconazole showed a highly significant reduction in fungal peritonitis when you treated them with fluconazole during their antibiotic treatment course. In our program, this is now part of our process. When we put patients with broad-spectrum antibiotics, the nurse asks the nephrologist, do you want the patient on diflucan? That's part of our process now. And I said this, but I think that when your patients get admitted, you need to talk to them. When they're admitted, I think it's useful to know that not all hospitals even have cyclers in place. They all should, but the management of hospitalized PD patients in some hospitals is truly woeful. I will tell you that it's much, much better to have an automated cycler because you can program that cycler for up to 48 hours, and you can do sorts of things with a cycler that you cannot do doing manual CAPD exchanges. The problem is manual CAPD exchanges require that an untrained nurse be involved in the process, and I consider that to be a very dangerous thing for your patients. The advantages to using the cycler are as follows. You have a dialysis nurse involved. Okay, it's much easier to do low volume exchanges, tidal exchanges, more frequent exchanges. You can program the patient to be on PD for, say, 18 hours at a time, and then they can come off their treatments between 8 o'clock and 4 o'clock in the day so that they can get procedures done, physical therapy, and that sort of thing. So we cyclers almost exclusively now when we hospitalize our patients, PD patients in the hospital, right? And the other thing that you really want to have is a good flow sheet to utilize. Now, hospital has a different flow sheet, those that do have flow sheets. I know DaVita is presently piloting a new flow sheet, but really this is the kind of thing that you should have in place. When nurses in the clinic, meet with the acute nurses, which you should be doing on a regular basis to make sure they're taking care of your patients properly. I think that you would want to see what kind of flow sheets that they're using, okay? But the flow ought to be able to tell anybody that comes into the room what's actually being done. This is the flow sheet that I typically have used in hospitals over the last couple of years. It's a pretty simple thing. Okay, so really quickly, I want to go through a couple of cases, and then I'm going to have to get off to answer questions. Here's a case of a guy that comes into the ER with a third episode of recurrent staph epiperitonitis. And he gets admitted. Normally what happens to a patient like this is because it's a third episode, people pull out his PD catheter, they place a hemocatheter, they treat IV antibiotics for 2 weeks. Then, several weeks later, maybe a new PD catheter is placed. More weeks go by. Patient starts PD and eventually has his hemodialysis catheter removed. And typically this takes about 3 months. 2 to 3 months of ongoing interventions until you get past this. What we did in this particular case was fairly simple. He came to the ER, he did get admitted, but he wasn't that sick, so we sent him home right away. We did treat him for 2 weeks for his staph epiperitonitis. Then what we subsequently did was we did a simultaneous removal and replacement of the PD catheter. He went home. We waited a day, but then we did, because a brand new catheter, is we had him do supine low-volume exchanges. Yes, we made him stay on the cycler for a longer time period. He wasn't able to work for several days. But the bottom line is by using a regimen like this, we were able to get him out of the hospital almost immediately, and he never had to go on to backup hemodialysis. The idea of using your cycler therapy in more novel and innovative ways allows you to do some really cool things for your patients. Here's an example very similar. This is a patient of ours that had been on PD for a while that developed a large inguinal hernia and had to come into the hospital to have it repaired. What do you guys do? Okay, well, a lot of programs would always put hernia repairs onto backup hemo. They would do the same thing with elective cholecystectomies or appendectomies, okay? But other programs that would rarely put these patients onto backup hemo. And I'm going to, it's a study from Spain. I'm not going to go into it, but the bottom line is there's a lot of studies that have been done at keeping patients on peritoneal dialysis after hernia repair. And it turns out it's really quite safe if you use a Dacron mesh to help reduce the tension on the surgical site, right? And so here's what we would typically do for a large hernia repair. Hernia fixed, we held the PD for a day and a half, but then we initiated low-volume supine exchanges on that patient, okay? In this case, we kept him there for 2 days, all right? But then he went home. We continued doing low-volume supine exchanges for a while longer, and then allowed him to go back to his normal regimen. The idea is by doing only supine exchanges, you reduce the intra-abdominal pressures, and quite frankly, we've had enormous success doing this. We've done this after cholecystectomies. We've done it after all kinds of minor or smaller surgical repairs to the abdomen. To do this, I think, is a great gift to your patient. Okay? Here's a case of a patient of ours on PD who came in with acute myocardial infarction, had to go to the intensive care unit. He comes in the ICU after surgery with an aortic balloon pump in the critical care unit. Now, the question to the nephrologist, right? And now your patient's in the ICU with an acute cardiac event. What do people do? I do know for a fact that there are many programs that would automatically put this patient onto hemodialysis. If you ask the nephrologist why they would do that, they would tell you because, well, isn't that what I'm supposed to do? I mean, I'm nervous to do PD in a sick patient. Okay? Well, to be honest, it doesn't make me nervous to do PD in a sick patient. And in this particular patient, it's no big deal to just leave him on PD. We make adjustments in his dialysis. We put him on to continuous cycled PD therapy. Okay, and the bottom line is the patient did perfectly well. No reason to submit that patient to the risk of a hemodialysis catheter. And quite frankly, I think PD is a safer therapy because of the hemodynamic issues. So the idea of taking your patients on PD and doing hemo every time they get sick, I think is a terrible idea. Hear about cases like this, you got to talk to your nephrologist and ask them to explain themselves, right? Okay. Now, because of time, I'm not going to really talk about acute PD. I'm going to run out of time. But I'll tell you that there is a role for acute peritoneal dialysis in people who were not on dialysis, who suddenly come in sick and develop acute renal failure. Almost everybody in the United States would put them onto either hemodialysis or CRRT. But I will tell you that in the pediatric population, people go onto PD all the time. And here's just one study from a small, impoverished third world country north of America, where they took a bunch of children and they put them on PD routinely for acute renal failure, and the patients do very, very well. Now, if you try to look at benefits of PD and acute renal failure, there are benefits, and I just put there to look at, but especially in places where cost or the resources required to provide hemodialysis is limited. This is what PD is often done in those particular countries. And some studies that I'm not going to really spend any time on, except to show you that the studies that I've reviewed that compared PD versus daily hemo or CRRT in acute renal failure, all those studies showed more problems with catheters and more problems with infections when they went to hemo than PD. The studies that I've reviewed suggest that PD is a completely viable option. Okay, it does require that a catheter get placed, and there's ways of doing it to make it safer, as itemized here. And there's a protocol that if any of you ever want to see, I can share this with you. But there are ways of doing this, I think, that are probably better. Would be candidates. I think that not everybody. I think that probably a majority of patients should have hemodialysis or CRRT. But cases like these where there's problems like this, I think PD ought to be an option. And I think the point is to have PD in the arsenal of options for patients who need dialysis in acute renal failure setting. Okay? So, how about this one? Unemployed construction worker shows up in the ER. No one's ever seen him before, but he's up with tiny little kidneys, a creatinine of 10.6, and congestive heart failure. If this were a patient in your dialysis program, how would his dialysis be started? This is just a reminder that Urgent Start PD is no longer a new therapy. In our clinic, that patient absolutely would have been started on Urgent Start PD. If you guys aren't thinking about Urgent Start PD and have the capacity to do Urgent Start PD, I'm telling you now, you're falling behind the times, because this is a very popular therapy, and we're seeing an enormous amount of success on it. Okay? So my last case then is older, an 82-year-old patient. Now, let me say it again. The wife of an 82-year-old diabetic patient gets hospitalized with a hip fracture. The problem is the only way that this patient was able to do PD is because his wife was doing it. Okay? So what happened is his wife is now in the hospital. Nobody knew what to do with this old guy, and so they admitted him to the hospital. He wasn't able to do his own dialysis. The question is, how would people handle this case? Because what really happens is people put hemodialysis catheter in this patient, and it goes on to hemodialysis because nobody can figure out how to provide this man with PD while his wife is unable to do it for him. And I want to remind you that there is an alternative to this, and the alternative would be to have that patient come into your clinic and have you provide him with his peritoneal dialysis. And studies that I'm showing here involve what they describe as intermittent PD, where the patient comes into a care setting 3 days per week, spend the day there, and get PD performed usually on a cycler machine for 10 hours a day. And the data that exist are really quite good. These are old, debilitated patients who get, by everybody's standards, suboptimal care with a weekly KT/V of only 1.0. But the point is, survival statistics were really quite good. And here's another similar study from Germany where these patients, on the average, survive for more than 26 months. So the idea that one of our bigger clinics, our more robust and innovative clinics, could provide patients with intermittent PD, a way to prevent hospitalizations or avoid backup hemo, I think is such an awesome and cool thing to be able to offer to your patients. If not doing it, if you have the capacity to do this, it's really, really, really worthwhile looking into it. In summary, you have a process for doing these things. If you think you're just going to do it by remembering to do it, you're going to fail. You have to have a process in place. I think you need to address weekends and evenings and make sure that everybody knows how things are supposed to be handled, especially your patients. You coordinate outpatient, inpatient care. Those of you that are PD nurses in a PD program who don't even know who the acute service is, I think you need to meet with them, integrate with them, and make sure they're doing things the way they need to do them. Okay? And in the end, up and take responsibility for the patients when they're in the hospital too, and in the end, the patients are going to do much, much better. And I'm going to end my presentation, and thank you all, those of you that are still on, for listening.
Thank you, Mark. Can you queue up for questions, please?
At this time, I'd like to remind everyone, in order to ask a question, please press star, then the number 1 on your telephone keypad. We'll pause for a moment to compile the Q&A roster.
And we do that, a reminder that you can ask questions in two ways. You can ask them yourself in person, or you can type them into the chat box on your webinar, and I'll go ahead and ask them for you.
Your question online comes from Pat Christensen. Your line is now open.
I was just wondering, the physicians using the Falcon for their thing now, it talks about a checklist, and many of the things that are on your checklist aren't in the Falcon, and they usually just go down in Falcon and, you know, do their note that way. Is there any chance for PD patients they may be changing that?
Well, I ask you because I don't know. I don't tell you my Falcon story, but we're not using Falcon right now. Does Falcon now have a PD progress note that people can use?
There's a progress note in there. Whether it's much different from HD or not, I'm not completely sure. But using Falcon to chart for PD.
Right. When we stopped using Falcon, they did not yet have a template up for PD, so I don't know. No one has ever discussed with me that a PD progress note should look like, and I've not seen it. So, John, I don't know if you know the answer to that. I kicked that question over to John Moran.
Uh-huh.
Forward and signed up. The answer is it should. Go ahead.
I'm still here, but John was on mute. Repeat the question, please.
I was talking about, you know, a checklist for PD patients that the physician should kind of follow, and, you know, the ACE, ARBs, the diuretics, that kind of stuff that he uses in his clinic. But that's not part of what's in the Falcon charting. Physicians use the Falcon charting, and I was just wondering if there was any thought of, like, in the future, add that to Falcon.
Absolutely. I think it's an idea, and I think the checklist should be that the physician may or may not agree with doing all of the things, such as, but at least it's put in their heads. It's absolutely we need to do.
It's hard to be really dogmatic about what people should do, and there's a lot of room for debate, but I think every individual program, physicians and team need to kind of identify what their philosophy is going to be, you know, decide what they want to do. But then the key is to do it. And I don't know how customizable those Falcon notes are either, because what would be nice is that, you know, you can take the Falcon template and then customize it to your particular program. I don't know if that's doable or not, but that's something we could look into.
Okay, thank you.
Again, if you'd like to ask a question, that's star 1 on your telephone keypad. Your next question comes from Penny Winkleman. Your line is now open. Penny, your line is open. If you're on mute, please unmute.
I would like to just make I had a question about the hernias and the coles. We have a patient who has a gallbladder who's had some problems with it and went to get it removed, and the surgeon told him that if he took the gallbladder out, he would be taking the PD catheter out too. And I was wondering if there's any way that we could get around trying to get him some information that maybe it's, you know, he wouldn't have to have that PD catheter removed if the gallbladder was removed.
Yeah, so unfortunately you have a lot of very rigidly minded surgeons out there that, you know, taught something 25 years ago and they haven't learned anything since then.
And have some hernias, a couple of patients that may need hernia repairs, and they always put them on hemo backup. And we've been hoping that they would just do low volume fills, give them a day off, maybe start out on some low volume fills, but they will ultimately take them off of PD, put them on hemo for a couple of weeks before they put them on PD.
I think that there are surgeons who actually speak about this very specifically, and there's probably 8 or 9 studies now that have addressed it. And what's really interesting is when hernia repairs are done properly, they almost never leak. It's a cultural thing. The best way is to try to put together the data. Sometimes you just have to use a different surgeon. So sometimes what you have to do is find a surgeon who then can do it successfully, and then sometimes the other surgeons will kind of learn from that other person's experience. You know, what we found far easier than teaching surgeons new tricks is to find new surgeons.
Right, and we had talked about that too.
Yeah, find a cooperative person who's willing to come to meetings, willing to learn. I mean, I made it clear in our program that if the surgeon wasn't willing to come and meet with us, that we weren't going to use them. Okay, and the ones that we use have all come. So, and with surgeons we no longer use, specifically because they're not willing to cooperate and do some of the things the way that we should do it. So, you really have to have a medical director who's willing to, review the literature, make themselves comfortable with the subject matter, and sit down with the surgeons and tell the surgeon what you want.
Right.
It's hard to do if you don't have a physician on your side that's willing to kind of back it.
We just hate to lose the patients. The patients have a patient who said, this Coley patient who said, I'm not going to tell you that I don't feel good then because I don't want to lose my PD catheter. So.
Well, I can't think of a reason to take the PD catheter. I can imagine situations where a surgeon doesn't want to use it for a little while, even though I don't agree with that. But the idea of taking the PD catheter out in an elective operation setting, I don't understand that at all.
Well, it said something about it could leak the gallbladder, so it could be infected. Then the PD catheter could get infected.
I think find a surgeon with more self-confidence.
Okay, thank you.
That comes from Lily Thompson. Your line is now open.
Hello, Doctor. First of all, I wanted to say thank you so much. The topics today have been really interesting, but what really caught my attention was the one that when you talked about the elderly guy and you brought him into the clinic for 3 times a week of the dialysis. We have a patient, she's been kind of in the hospital for a while, and I spoke with the doctor yesterday, and they want to bring her out. Now, the problem is they have no other places for her. She's a diabetic, and, to put a hemo, so we're keeping her on PD. But the challenge is someone being there for her during the day. Now, you mentioned about the patient coming into the clinic for 3 times a day. Now, this is a 3 times a week. Now, this is a young lady. She doesn't weigh that much, and you say do dialysis for 8 hours. And what I was concerned about was the clearances. DaVita say that we have to have creating clearance of 1.7. I know before she went into the hospital, she did have some residual urine function. I don't know if that was lost during the hospital stay because she went through so much, but I approached the physician about something like that. Could you give me some suggestions as to what I would say or how I would go about it and how I could explain to him that this might, I know it help the family.
Yeah, so first of all, don't quote me. Just because DaVita says something doesn't mean that it's biblically or divinely inspired. Okay. Understand that when we talk about a clearance of 1.7 being the minimum, we're talking about chronic care, long-term care. And what we're proposing by doing intermittent PD is not necessarily intended to be an optimal therapy. But sometimes you can't do what you would optimally like to do. Sometimes you have to do things that are not optimal. And so you do the best that you can under the circumstances. Probably not realistic to have a person come in 7 days a week into your clinic to do PD. Okay? What I'm suggesting to you is that our data support the notion that you can successfully do PD in an intermittent way like those slides showed, and still the patients do quite well. What I quoted there were KT over V in the one study of only 1.0. We all know that that's not optimal long-term care. But to do that for a couple of weeks, the patient's probably going to do just fine. If you stop doing dialysis altogether, the patient would probably die, right? Do it 3 times a week probably is going to provide enough dialysis the patient will do just fine for a couple of weeks until the situation gets better. Now, it's a lot of work. You've got to use your resources. You've got to have space. The patient's got to sit with you all day to do this. I'm not saying that this would always be the right choice, but it's kind of cool to think that you could do this for your patients.
Well,
once in a while.
I really like the idea. I think it's really nice. I just wanted to know, and I wouldn't even mind doing it like for the 4 days. But
I'll tell you something else. We've actually done patients like this now on the hemodialysis floor. Because in some clinics, they just don't have enough space to have a patient sitting there all day doing exchanges. And so we actually have a process in place, DaVita does, where you can actually have patients in some situations actually do their PD on the hemodialysis floor. Okay? You start expanding your mind about what you can do and what care you can provide for your patients. There's really some neat opportunities. It does take a little bit of work and a little bit of commitment, but we do a process in place for doing that now.
That's really great because here we don't have a nursing home that do the PD, and sometimes we lose our patients. But what you're saying, I mean, it sounds good. We couldn't take 2 or 3 of them, but maybe like 1. And in my case, I just have 1. And
exactly. And we know the nursing home situation is a really, really big problem. When you're honest about your patient losses, a lot of losses are when people move into a nursing home. They fall, they break a hip, they can't stay on PD in most cases. And so doing intermittent PD in the clinic is not the solution for every case, but it be the solution for some cases.
Well, Dr. again, I thank you so much, and you know what, I really feel good, and I'll speak to my physician and to give him something to think about and talk to the family too, and I think that will give them a little time and maybe monies together to get the care for the patient, and we'll work it from there. But I thank you so much. I never thought about that. So thank you so much.
Thank you. That's great. I'm glad to hear that.
Thank you.
Go ahead and ask a question here from our chat box to make sure that we get to some of these, and then Sarah, I'll prompt for additional audio questions. I'm here for you, Dr. Shapiro, doing PD after a total hysterectomy. What are your suggestions?
Trying to believe we've ever done PD after a total hysterectomy, and I don't think that we have. I'm trying to think about the approach on a total hysterectomy, and the answer is it would be a fairly large incision site. John, I ask you, have you ever seen a patient done after hysterectomy? Because I don't know that I've ever had one.
Acutely after the hysterectomy or in the long term?
I think acutely after the hysterectomy.
Yeah, I've never seen one.
Yeah,
I think that would be difficult.
Right. So when we talk about keeping people on PD, we've got to still use pretty good judgment, right? And the last thing in the world I want to suggest is that every surgical procedure ought to keep the patient on PD. I think that when you're talking about a fairly large operation with a fairly large incision, you probably have to put these patients on backup hemo for a couple of weeks. The same thing would be true after any kind of abdominal emergency, right? When I talk about doing it after cholecystectomy, I don't necessarily mean after acute fulminant cholecystitis, where patient's really sick and has a markedly inflamed gallbladder, where we're talking about a bigger, urgent operation. I'm talking about more elective procedures where we know that the surgical incision sites are usually laparoscopic in nature, and they're pretty small in size.
Thank you. I'm going to read one more here. What about using biofilm when placing a new PD catheter? Does it make a difference?
I don't really know of any data on that, but I can answer the question. I don't know of any data on that.
I think there's data from the past showing that if you're concerned about biofilm, replacing a PD catheter is more effective than trying to deal with it by using urokinase or whatever to biofilm. And I think it's pretty clear that you can take it and replace it at the same time. Take out the catheter on the right-hand side and put another new catheter in on the left-hand side. Always viewing you've got body cover.
Yeah, you get right. So biofilm after infection. Yeah, I'm sorry. So the caveat to doing that, I think, is that you have to now have an abdomen that is no longer infected, okay? And so still inflammation in the abdomen, I don't think anybody would recommend replacing a catheter at that time. We have used TPPD catheters a couple times for recurrent infections, but John's so right. There's really no data reporting it. Did you do it after the second infection, after the third infection? We typically consider it after the third infection because we've treated a number of people successfully after a second infection where it just went away after the second round of treatment.
Thank you. Do we have any live questions in queue?
Questions queued up at this time.
Great. I'll go ahead and read another one. Dr. Shapiro, would you review the details about physical therapy for ESRD patients after hospitalization? You mentioned them during your presentation.
Well, yeah, there's a lot. There's quite a few studies looking at ESRD patients and in some cases PD patients that talk about the benefits of exercise. And really all the studies that have been done have been largely supportive that functional status improves with exercise. In some cases, a reduction in hospitalization and other things. I think the point about physical therapy is first of all, simply having the diagnosis of ESRD under Medicare rules does qualify you for physical therapy. All right. So the idea is, in all of our new patients who start therapy, a lot of them begin really quite debilitated. And although they're really overwhelmed with all the things that they're doing as they start dialysis, in many cases, adding physical therapy to the list is going to move them along more quickly from a functional status point of view. And after hospitalizations, when people come out really debilitated, I just think it's something we sometimes forget to do. I don't really know the data on physical therapy per se, but I think that these people come weak and debilitated, that they're at very high fall risk, and anything that we can do to minimize the likelihood of a fall, I think is going to improve those outcomes. So, that's something to, I think, just have on your checklist list for all new patients and after every hospitalization is whether this patient might benefit from getting physical therapy.
Thank you. Another question here. Would you use a patient who had a colonoscopy and had a bowel perforation that resulted in peritonitis? He did receive pre-med.
So I'm assuming this patient is already on PD and develops a perforated bowel in the context of being on PD. In that case, you're almost always going to have a significant abdominal operation where you probably aren't going to keep that patient on PD. Some people would recommend taking out the catheter at that point because the bowel, because you've got a perforation and you've got a soiled abdominal cavity. And I think in general in those cases, most people would take the PD catheter out. I can't recall a case where we didn't. I don't know why we didn't, but we did. That patient actually did pretty well. I think in that case, most people would remove the PD catheter after true, sort of abdominal event with, fecal peritonitis. I mean, this is a life-threatening event, right, where the patient may die from this. And I think you've got to do every little thing that you can in that case to improve the likelihood of survival.
Thank you. And I'll go ahead and read our very last question here if there are none queued up. Sarah, do we have any in queue?
Still no questions. Thank you.
Great. Last question here. What dose of antifungal do you use while on antibiotics?
Yeah, so we use the study I showed on the slide. It's a study from Columbia, and what they used was fluconazole 200 milligrams every other day throughout the course of the treatment. And we use the same dosing, mostly because that's what they used in their study. The controversy over the use of fluconazole, is the concern that it might lead to fungal anti-fluconazole resistance in the fungus. Since we use diflucan as our main treatment when people develop fungal peritonitis, the worry is that if we use it widespread as a prophylactic therapy, we're going to end up getting cases that are resistant to it. I've not ever seen a case. I've not heard of a case. I did try to look through the DaVita database and could not actually get the information on what our fungus show in terms of resistance patterns. Don't actually have that data. But that's the argument. The problem with using nystatin is the data are really not very strong. The studies that have been done have not been very conclusive at all that you actually lower the risk of fungal peritonitis. And so why we've chosen to go with diflucan. I think that this is, again, a really program-by-program individual decision. If you've never had a case of fungal peritonitis, you probably wouldn't be inclined to use it. If on the other hand, if you've lost 3 patients over the last 2 years, you might be more inclined to use it. So I think it's program-by-program decision.
Thanks so much. And we are at the top of the hour, and that was actually our last question, so right on time. Thank you. So we're going to go ahead and stop here. I would like to take a moment to thank everyone again for participating. I know that you guys are busy and have lots of things to do, so taking time out to learn more about how to care for your patients is certainly appreciated. I'd especially like to thank our speaker, Dr. Mark Shapiro, for taking time away from his busy schedule to speak with us here today. Please make sure that you join us for our next PD webinar. That next webinar is scheduled for Friday, March 1st, and our speaker, Joanne Bargman, will speak on comorbidities and how to manage comorbidities in PD patients that have diabetes. Reminder for those nurses in attendance, you are eligible to receive 1 continuing education credit for this webinar and for each of the webinars in our series. And for those who are looking for the CE code or the learning code for today's webinar, that code is CEC2147. That's Charlie Echo Charlie 2147, and I'll go ahead and email that out to the group as well. Thank you, everyone, for participating, and have a great day.
This is today's conference call. You may now disconnect.